Assalamu alaikum. Welcome back. Good evening and good morning to everyone. I would like to, honestly, it's my pleasure to introduce the chairperson for next sessions. He's the Dr. Ramez Swalim. Dr. Ramez, he's the senior rheumatology consultant at Prince Sultan Military Hospital in Riyadh. He was a past president of the Saudi Society for Rheumatology. Dr. Ramez, he published a lot of scientific papers and researches in the rheumatology field. I would like to welcome you again, Dr. Ramez. Please, the microphone is yours.
Thank you very much, Dr. Fahed, for your kind introduction. And I extend my thanks to the Scientific and Organizing Committee in the Saudi Society for Rheumatology for their well-appreciated effort to make this activity happening at this difficult time. Today we have, this session is a very exciting session for everybody. Lupus is our wonderland. It is everywhere we go, they are in the main auditorium, the lectures on lupus. And there is no better than Dr. Michel Petri to talk to us about the lupus nephritis new approach and optimal management. Dr. Petri is the professor of medicine at the Johns Hopkins University School of Medicine. She attended medical school at the Harvard University, and she did her internal medicine residency at the Massachusetts General Hospital. In addition, she completed 2 fellowship programs at the University of California, San Francisco in allergy and immunity, as well as rheumatology. Dr. Petri is the director of the Hopkins Lupus cohort, and she is a co-director of the Hopkins Lupus Pregnancy Center. So the mic is yours, Dr. Petri.
Hello, my name is Michelle Petri, and our topic is lupus nephritis, new approaches, and optimal management. Here are my disclosures. We are going to be concentrating on the information from the ACR Convergence 2020 meeting. And here are my learning objectives. I want to start with the terrible burden of end-stage renal disease in people with SLE. In our cohort, 8% of my patients will be in renal failure within 20 years, remembering that people with lupus are usually diagnosed in their early 20s. In those who develop lupus nephritis within 1 year of their diagnosis, though, the risk of end-stage renal disease is a whopping 23%. The risks are higher in men, African Americans, those diagnosed at a younger age. I think you know that pediatric lupus almost has universal nephritis, and those with active serologies. Among all the immunologic markers, low C3 is the strongest predictor. Here are some US national data, though. These come from Michael Ward. And what you see is no downturn in progression to end-stage renal disease. These lines are flat. And you can see the obvious problem we have, that it's much higher in African Americans than Caucasians. In the United States, Hispanic Americans have a worse risk than Caucasians. And in the United States, lower socioeconomic status is also a risk factor. I learned such an important message from Professor Anders, who's a nephrologist from the Netherlands. And his take-home message is the title of my slide, that nephrons once lost are gone forever. And I think both we, the treating physician, and the patient need to hear this message. At the very first episode of lupus nephritis, there can be a 1/3 loss of nephrons. Now, the remaining nephrons hypertrophy, so we end up overestimating the amount of renal function remaining. Now, of course, as anyone ages, including us, there's a gradual loss of podocytes and nephrons. So here in blue, you see, what's just going to happen in us. But here in red is that 1/3 loss with the first bout. Well, what if everything is perfect and the patient goes into renal remission and no flares? Well, then, she's still likely to be okay. But you and I know things aren't perfect in lupus nephritis. It may take a long time to achieve a renal remission, or she may never achieve it. So she's continuing to lose nephrons. So you can see this is her trajectory. And this is why Professor Anders teaches that most of our lupus nephritis patients will be on dialysis by age 70. So what's our goal? Our goal in the clinic has been to try to have a target for the urine protein to creatinine ratio. And there have been several potential targets published. I like the 500 one, which is part of the EULAR guidelines. But other people have used the 700 milligram target. Maria Delara, though, has taught us using real clinical trial data that rapid resolution is best. Now, basically, we want our patients to enter a renal remission. And here you see that if they do, they're not going to end up on dialysis. If someone has a 50% response, though, over half are going to end up on dialysis. And if you have no response, well, then the great majority will end up on dialysis. So let's look at some of the real-world data that came out of the ACR 2020 convergence meeting. And I want to start with our gold standard treatment for lupus nephritis, which is, of course, mycophenolate. But there's very little guidance on, when you can taper it. And I think you're aware that in the EULAR guidelines, it says you treat for 3 to 5 years and then you taper. Of course, you always taper prednisone first, of course. Well, here is a study suggesting that it might be possible to taper mycophenolate after just 2 years of control of renal disease. Now, of course, it needs to be done slowly. The way I do it is I taper by 500 milligram increments, but never more often than every 3 months. Because if the urine protein creatinine starts to go back up, I want to backtrack to the previous mycophenolate dose. Please remember, mycophenolate must always be dosed twice daily because it's only bioactive for about 90 minutes after it's absorbed. So don't let the patient contract the regimen to once daily. It must always be twice daily. And then there was a very important plenary on hydroxychloroquine. Of course, everyone now knows it doesn't treat COVID, but the issue that arose from COVID data was whether there were cardiac arrhythmias and whether that was related to QT prolongation. So Elizabeth Park in the plenary presented these data, which are based on 3 cohorts of rheumatoid arthritis and lupus patients. And it was very reassuring. Now remember, these are our rheumatology cohorts. COVID is different. Patients with COVID have COVID involvement of the heart, and they were being given many other medications that affected the QT interval, and they were being given hydroxychloroquine doses that we don't use in clinical practice, 600, 800 milligrams, that kind of thing. So using our kinds of doses, there was no problem. So I thought this laid to rest one of the major worries that came out of the COVID pandemic for our clinical care of our rheumatology patients on hydroxychloroquine. But now to new treatments, because this is a very exciting time for lupus nephritis. And incredibly wonderful for me, a lupus person, to have the ACR 2020 convergence meeting be so chock full of lupus. So here is the BLISS lupus nephritis phase 3. And what's truly remarkable about some of these lupus nephritis trials is the duration is 2 years. You can't even begin to imagine keeping people in a randomized trial for 2 years. Now, the primary efficacy renal response was actually defined saying less than 700 milligrams. But also this 2-year trial met it for less than 500 milligrams as well. And you see the delta there, 43% versus 32%. an odds ratio of 1.55 and a p-value of 0.03. In the ACR 2020 convergence presentation, Rich Fury also gave the information that we would have expected with belimumab, that it does, of course, meet SRI-4, it increases complement, and it still has, a really good safety profile, even when added on top of the 2 renal regimens that were allowed in this trial. So both mycophenolate and urolupus cyclophosphamide were allowed in this trial. Now, in addition, the Nobility or obinutuzumab trial was presented. Now, obinutuzumab, think of it as the next generation rituximab. Rituximab was unfortunately negative in the LUNAR trial for lupus nephritis. And immunologists have been trying to figure that out. And there are a couple of theories of why it was negative when added on top of mycophenolate. And the first is that many lupus patients did not completely B-cell deplete. And then, the second explanation is, when you give rituximab, there's actually an increase in BLyS or BAFF levels, which of course allowed those remaining autoimmune B cells just to recrudesce and bring back the disease. So the advantage of obinutuzumab is it's a much better B-cell depleter. Now, this again is a 2-year result, but of a phase 2 trial. This one is not ready for the FDA yet. This is just phase 2, but remarkably promising. So I want you to see here, the complete renal response. This is, remember, less than 500 milligrams, and a redefined complete renal response that was a more fair representation of GFR. So both of these have an incredible delta. We're not used to seeing this kind of thing in lupus nephritis. So, no bad safety signals, but of course we have to wait for the phase 3. Now, the next one, these are older data, but I wanted to remind you that there's going to be a third player for lupus nephritis, and this is the next generation calcineurin inhibitor, voclosporin. It involves just a small chemical change on cyclosporin that allowed it to have much better pharmacokinetics, so it can be a fixed dose twice a day, easy. And this is fast. You can see on this slide the partial and complete renal response defined as 500 milligrams less than that at 24 weeks. And look, the complete response is even better at 52 weeks. Look at that odds ratio. Look at that p-value. And it is definitely faster than mycophenolate. Again, look at those p-values. Now, as a calcineurin inhibitor, there is going to be a protocol, the one that was followed in this phase 3 trial, for those patients that have a reduction in their eGFR. This did not appear to be a big deal. So this is awaiting FDA approval. So for both belimumab and voclosporin, our hope is FDA approvals early in 2021. These are going to be game changers for us in clinical practice. Now, there's going to be a huge amount of new basic science data, and it's coming from the Accelerated Medicines Partnership, or AMP, that is funded by the Foundation of NIH and NIH. And what is very different is these involve kidney biopsies, single-cell RNA sequencing on cells from those biopsies. Now, there was an early part of this called phase 1 that's already been published. And what it showed was that a lot of the action is not in the glomerulus, it's in the tubulointerstitium. And the tubular cells from patients with lupus nephritis expressed higher levels of interferon response genes in this phase 1, published by Evan Durr and colleagues. So these kinds of scientific advances are going to identify new pathways that we didn't realize were important. But they're going to also help us with our failures. So the people in phase 1 with lupus nephritis who were non-responders at 12 months already in that first biopsy had upregulated their fibrotic pathways in the tubular cells. And please think how woefully inadequate we are in preventing fibrosis and lupus nephritis. You know, we use ACE inhibitors and ARBs, don't we? But they do, you know, just a small amount. And vitamin D in experimental models may have an anti-fibrotic role in pulmonary fibrosis, but we don't know in lupus nephritis. So we want to know what's going wrong in those patients who are destined to be non-responders. So a huge amount of ACR 2020 convergence turned out to be from the AMP study, no surprise. And I wanted to tell you about the urine proteomics arm, because what I'm really interested in as a clinician is let's take these results and translate them so you and I can measure them in the urine, because we can't be doing kidney biopsies every visit. So a platform called Kiloplex is used where 1,000 different urine proteins can be quantified. And Andrea Fava in a plenary went over what is found in the urine proteome as part of AMP. And you're going to get used to looking at these. These are called volcano plots. And here you see the big differences on the left in healthy controls, and then here on the right in the lupus nephritis patients. But in particular, in the urine proteome, it's possible to separate out the patients who have membranous from those who have proliferative. And these targets turn out to be pathways that are involved in chemotaxis of all the inflammatory cells. And what you see here in the arrow is he was able to identify a brand new target in the urine proteome called interleukin 16. And it turned out that interleukin 16, along with several other proteins in the urine proteome, were highly correlated with the histology. And interleukin 16 in particular is not correlated with proteinuria, because you don't want to rediscover the wheel, right? We can measure proteinuria. We want to have clues to things that might be present before proteinuria. And of course, as you would expect, interleukin 16 is made by those infiltrating immune cells in the kidney. So what we measure in the urine is coming from the kidney. And it's one of the most abundant, so it's not going to be hard to measure it. So because Dr. Fava's in my group, I'm of course biased, but I thought his presentation opened up a lot of important new messages. But there was even more. So you know how many patients have more than one kidney biopsy? So Dr. Fava also presented at ACR 2020 a way to understand why so much confusion revolves around membranous nephritis. You know, do we treat it aggressively? Do we not treat it aggressively? Well, one of the problems is some patients with membranous go on and develop end-stage renal disease. And what he was able to show is on previous biopsies, those were patients that had some proliferative in the kidney. So as you know, patients shift classes on serial kidney biopsies, but most proliferative patients stay proliferative. It just sometimes when someone looks like they have membranous, in fact, their past biopsy had proliferative. So we do want our renal pathologists to be aware of this and to always count the chronicity index in patients with membranous. Now, the AMP clinical results are already known. The phase 2 basic science results will be known by the end of this year. And one thing that is a very clear message is that our patients who've had just one biopsy are more likely to be complete responders at 1 year, but it's still only 40%. It's still awful. And these were, you know, academic centers that are the world leaders in the treatment of lupus nephritis. For patients who have had a repeat biopsy, their chance of getting a complete response is much less. I guess that's no surprise, right? It's like in rheumatoid arthritis. If you're already a methotrexate non-responder, you're not going to do as well. But another important message that's come out of AMP clinical findings is that we should be biopsying patients at 500 milligrams. There's no reason to wait for 1 gram. And so, you know, the rule about biopsying at 500 milligrams is already part of the EULAR guidelines. There is a difference. If you wait until after 1 gram, you're more likely to see an active urine sediment. When you biopsy at 500 milligrams, the urine sediment is less likely to be active, but you still can pick up patients with proliferative. So the message has always been, when you pick up lupus nephritis earlier, you're more likely to have a success in your treatment. So please do start to biopsy at 500 milligrams. Now, you know that many of our patients are going to do poorly. And you saw in my own cohort, if you have lupus nephritis within the first year of diagnosis, you're going to have a 23% chance of going into end-stage renal disease within a couple of decades. So those patients don't all get transplants. Many of them end up on dialysis. And we know that there is shortened survival on dialysis. There's no doubt about that. As you know, atherosclerosis is accelerated, there are infections. You know, it's just awful what happens to our young patients with lupus on dialysis. So I thought that this ACR 2020 presentation was actually some good news. And this came from April George, and what she showed was that once you get your transplant, your risks go way down for later cardiovascular events. It's like you could have a redo. So I so much like her work. You know, she's the one that showed when people had to stop hydroxychloroquine, you know, the 4-fold increase in mortality. She's doing excellent work. And I thought here was some good news and why I never, ever give up pushing for a kidney transplant in my patients who are on dialysis. So I hope you're now as impressed as I was with ACR 2020 Convergence. It was just a wonderful meeting. Virtual was obviously not anybody's first choice, but the science, the quality of the presentations was just top-notch. And perhaps the best meeting ever in terms of dissemination of new information about lupus nephritis. Thank you all very much for your attention.
Thank you very much, Dr. Michelle. I enjoyed your lecture as usual very much. Belimumab, what's the place now? Where you are going to put it? Are you going to use it as induction with Celcept, or you will use it for patients who are resistant or when they flare?
Some good news, belimumab was just approved by the FDA for lupus nephritis this week. As with any new therapy, there's going to be more than one way to introduce it. It could be appropriate to introduce it along with mycophenolate or urolupus cytoxan for induction. I think it's also just as appropriate to add it in patients who are not achieving a renal remission with mycophenolate or urolupus cytoxan. I can think of several particular niches for belimumab. The first is if the patient has a lot of non-renal lupus. They'll get both renal and non-renal benefit. And the second is a patient who already has a GFR reduction, where there might be reluctance to add a calcineurin inhibitor. And the third might be a patient who's already having infection issues, since belimumab, although nothing has a perfect safety record, has had a very reasonable safety profile.
Okay, thank you. There's one question about mofetil. When you taper down mofetil, do you do it depending on the absolute values of proteinuria or on the trend?
I want there to be a maximum benefit. My hope is that means a patient has achieved a renal remission, meaning 200 milligrams. But if the patient is only able to achieve something between 200 and 500. I'm not seeing any more downward improvement. Then at that point, it might be appropriate to see what happens when the mycophenolate is reduced. I must tell you though, in my own practice, quite often I find when I try to reduce the mycophenolate, the urine protein to creatinine ratio goes up. I have patients who've been on mycophenolate for longer than a decade. Every time I try to reduce the dose, their proteinuria rebounds. So I think everything must be personalized. Perhaps the most important message is, if you've tried to reduce the mycophenolate, recheck frequently that the reduction is working.
There's one question about best time to transplant for lupus nephritis. Is it early or late?
We would prefer that patients have what's called a preemptive transplant, which means you don't wait until they're on dialysis. Those patients do better. In the United States, though, we have a shortage of available kidneys for transplant. So unfortunately, many of my patients, especially my African American patients, have to go on dialysis first.
Do you taper hydroxychloroquine in SLE patients with end-stage kidney disease?
Yes, we should be reducing the hydroxychloroquine dose in those with end-stage renal disease. And the dose that I usually use is 200 milligrams after each dialysis. For patients with renal insufficiency, we also make a reduction, but I also strongly believe in tracking hydroxychloroquine blood levels, because we have found that the blood level is a much better predictor of retinopathy and a much better associate of efficacy than our doses fixed by real body weight or renal function.
Okay, then our last question. If a patient with lupus nephritis has no response or partial response to MMF or cyclo, would you switch to another medication, or would you add belimumab?
If the patient has had at least a partial response to mycophenolate, I want them to stay on the mycophenolate, and I would then add another agent. And remember, there are choices, and among the choices would be belimumab, a calcineurin inhibitor, either tacrolimus or when it becomes available, voclosporin. And in many countries, rituximab is still a choice. So I think that there should be some freedom of the rheumatologist and nephrologist to decide which one they want to go to as an add-on therapy.
Okay, thank you very much, Dr. Michel. It's a great lecture. Thank you.
Thank you.
Now we will move to our second speaker, Dr. Joanne Merrill. She is the Director of Clinical Projects for the Arthritis and Clinical Immunology Program at the Oklahoma Medical Research Foundation, as well as the Chief Advisor for Clinical Development of the Lupus Foundation of America. She has more than 260 peer-reviewed publications in the field. She will talk about antiphospholipid syndrome, from diagnosis to the new approaches of management. So please, Dr. Joanne.
Hello, everybody. I'm Joan Merrill, and I'm going to talk about the antiphospholipid syndrome today. I will say that I am very honored to have this invitation. Here are my disclosures. I want to acknowledge that this is derived from a lot of presentations that were given at the American College of Rheumatology meeting this year. And what I provided for you here are links to all of the original talks, because I can't possibly cover all the very interesting things that were presented by these people. We're going to review current treatment recommendations for the antiphospholipid syndrome. And one of the things that's been thought about a lot by the field lately is that we should be considering higher risk clinical and pathologic variables. I'll cover a little bit of that. And then in the end, I want to compare the COVID-19 coagulopathy to what we know pathologically about the antiphospholipid syndrome, and particularly the catastrophic antiphospholipid syndrome. Thomas Ortel spent some time thinking about and presenting the 2019 EULAR recommendations for the treatment of the antiphospholipid syndrome. And I'm going to cover some of what he did and maybe make a few other comments as well. The EULAR working group wants us to consider when we choose treatment for our patients, whether or not they have a high-risk antiphospholipid syndrome profile. They did a very large literature review and thought very hard about how we ought to be sorting these patients out in terms of risk based on the literature. And I will say as we go along that when they make recommendations, they are able, through their wording, and I'll show you in a minute, to differentiate recommendations that actually have more weight in the literature and those that might be just something to consider. So a high-risk antiphospholipid profile is defined as the presence at least seen two times, at least 12 weeks apart, of lupus anticoagulant, which by itself is considered a high-risk finding, or two or more of the big three, I guess we can call them, the most commonly used diagnostic antibodies. So lupus anticoagulant, anticardiolipin, or anti-beta-2 glycoprotein 1. So if you have two or more, and particularly there's literature about people who are considered triple positive, that puts you in a high-risk category. And then finally, people who have persistently high-titer antiphospholipid antibodies are considered high risk. And so when they give recommendations, they sort of want us to think about, which of this, whether or not people fall into one of those groups. But for, several decades, we've known that these three diagnostic measurements are really not all that we see in people with these syndromes who have a spectrum of autoantibodies to structures in the vasculature that range from lipoproteins to endothelial antigens and any number of odd combinations of structures that we have in our blood vessels. This was reviewed by Laura Bertolucci at the American College of Rheumatology, and she reviewed the information on something that has caught a lot of attention, which are antibodies to domain 1, D1, of beta-2 glycoprotein 1, and concluded that antibodies here don't really add a whole lot of diagnostic value if you're going to do a panel of antibodies. However, for many years, we have known about antibodies to antiphosphatidylserine, and these are as prevalent as anticardiolipin antibodies, and there have been many, many papers for decades saying that these may be particularly interesting when you're looking for people with high risk. More recently, we've understood that antibodies to antiphosphatidylserine with prothrombin, when, of course, prothrombin may be settling itself on activated cells where antiphosphatidylserine has come to the surface. Those antibodies may be particularly important and overlap somewhat with a lupus anticoagulant. And I'm going to get to this in a minute. It's not 100%. But if you look at that diagnostic test and look at the literature, they do improve the diagnosis and risk assessment. They're independent risk factors for thrombosis. They're independent to some extent of the presence of lupus anticoagulant. Of course, we have different ways of measuring things, and that kind of alters our ability to perceive what we're looking at. But they do have risk additive to other routine antiphospholipid tests, and may be the best at giving us some diagnostic accuracy or specificity for the syndrome, besides the lupus anticoagulant and the anti-beta-2 glycoprotein 1. So they may help us to identify additional patients with antiphospholipid syndrome, and I'm going to get back to these antibodies, so remember them. Antiphospholipid titulcerine linked to prothrombin. The EULAR recommendations did want us to consider some overarching principles, and I'm going to focus on that first one, which is risk stratification. Again, people at higher risk may have that high-risk antiphospholipid antibody profile, which I mentioned before, again, which includes multiple antiphospholipid antibodies, lupus anticoagulant, or persistently high titer antiphospholipid antibodies. But also if there's a history of thrombotic or obstetric antiphospholipid syndrome, coexistence of other systemic autoimmune diseases such as lupus, which itself confers a kind of high risk for coagulopathy, and the presence of many traditional cardiovascular risk factors, we should be stratifying those patients into a high-risk profile, and in determining treatment, we think about that. I also want to point out that there are ways of looking at some of these antibodies, and there's a very large literature on how they may activate inflammatory cells, and in particular monocytes. So there was a paper presented by Perez Sanchez at the ACR looking at some very interesting aspects of monocytes from patients with the antiphospholipid syndrome. So both the methylation profile, and what that means is the methylation status of inside the nucleus of proteins may have a large impact on which genes get turned into proteins. So it's been a whole field that's opened up in the past 10 years. But notably that if you look on the left, and you see sort of a lot of dots that are green and a lot of dots that are red, they were able to identify 816 genes that were differentially methylated compared to healthy controls when you looked at people who had antiphospholipid syndrome. And this is in monocytes. So the red ones are the ones that are elevated compared to controls, and the green ones are the ones that are lower than controls. And if you look over at the right side of this presentation, you'll see that they also looked at expression levels of these genes. Were they starting off to be turned into proteins, making RNA and being turned into proteins? And again, they found the same thing, that there were many genes that were elevated and many genes that were lower. If you look at the Venn diagrams, these circles on each of these sections, you'll see that there's a large area in both that's red. These represent adhesion molecules. So there is differential methylation and expression of genes that are associated with adhesion. I'm just going to give you a little hint here about what I'm going to get to later and say that adhesion molecules on monocytes, some of the most important ones are complement receptors. So I'm just going to sort of like put that in your brain for later. But the main thing that I was really getting to in that past slide is that patients with the antiphospholipid syndrome have quite a lot of things going on that may involve inflammation and complement activation. Back to the EULAR recommendations. They gave some recommendations for primary thromboprophylaxis that focus primarily on low-dose aspirin, and you can come back and read those in great detail later. And then I think importantly, there were some recommendations that are quite clear for secondary thromboprophylaxis. So for venous thrombosis, vitamin K antagonism with a target INR of 2 to 3 is recommended. When they say recommended, they mean there's a good literature to support it. They pointed out particularly that rivaroxaban, which is a direct oral anticoagulant, should not be used in patients who have triple positivity for antiphospholipid and triple positivity for antiphospholipid antibodies because there's a high rate of recurrence. I'm going to show you a little bit of that data in a minute. And they also distinguished between an unprovoked first venous thrombus and a provoked first venous thrombus. And they're really considering that you might want to treat even one that's provoked, such as after a long plane flight, but they don't have enough literature to defend it entirely. So instead of saying they recommend it, they say it could be considered. If there's a recurrent venous thrombosis, despite vitamin K antagonism, and where there had been an attempt at a target INR of 2 to 3, they recommend that, consider whether you actually had achieved that INR and what you can do about that. But if you did, then you could increase the INR target to 3 to 4 or change to low molecular weight heparin. But again, they used the term may be considered, so we still don't have enough literature that's defendable to be absolutely certain about this recommendation. I want to make a point about the differences between vitamin K antagonism and direct oral anticoagulants, most of which have something to do with the inhibition of thrombin. So we have, for oral agents, we have both at least one inhibitor, direct inhibitor of thrombin, and then we have several that are inhibitors of factor Xa. As you can see here, and I put those in little blue triangles. Vitamin K inhibition really affects a number of factors, 2, 7, 9, and 10 that are made in the liver that depend on vitamin K. And so basically we get lower levels of these factors when we have a vitamin K inhibitor. So these are quite different to each other, and there's been a lot of confusion about when you want to use one and when you want to use another. I'm just going to make a personal comment. I've spent many, many years of my life worrying about my patients on vitamin K antagonists, particularly warfarin, and I am concerned that it's not the optimal therapy, even though what I'm about to tell you is that it's not dead yet. So if you look at what literature we have, and it is somewhat limited, it does not look as if direct oral anticoagulation is optimal either. On the left, we have a randomized controlled trial, which patients were entered who had at least 2 measurements for antiphospholipid antibodies, 60% of whom were triple positive, which is a particularly high-risk situation, and looked at time to events. And what you're seeing here is that if you were on a direct oral anticoagulant, the time to events was shorter than if you were on vitamin K antagonism. And similarly, the TRAP study on the other side, in which all of the patients were triple positive, showed the same difference. So there is more likelihood of thrombosis on the direct oral anticoagulant. In both cases, they only used rivaroxaban. So there's much work to be done to be sure that this applies to all of them. But also, I will point out that there was another study suggesting that rivaroxaban is associated with greater thrombin generation after patients were treated for venous thromboembolism. The group also gave recommendations about arterial thrombosis, and I think the main point that they made, and you can go over in detail later, but the main point that they made is that aspirin alone or low-dose aspirin alone is not sufficient, and they are recommending vitamin K antagonism here too. This is actually some of the data that Dr. Ortel showed from the APS Action cohort study. You can see that the percent of patients without recurrence of thromboembolism was lowered really a lot more with aspirin than with anticoagulation, but when you put them together, you got a better impact. Now, I want to move to COVID-19 disease. Several reports, and one was published in the New England Journal of Medicine, suggest that antiphospholipid antibodies are a little more common in COVID-19 disease than we expect, even though people in the ICU will frequently be found to have these antibodies. People with viral infections of any kind often are found to have these antibodies, and whether or not they're pathologic in every situation is kind of controversial and not really known. But they seem to be a little bit more common in COVID-19 disease than in other illnesses. And this is a paper presented by Le Joncourt. It was actually a poster at the ACR. who looked at 104 patients and looked at the antibodies. 47% of them, that's pretty high percent, had at least one positive antiphospholipid antibody. And note that almost 39.6% of them actually had a lupus anticoagulant. 11% had thrombotic events, and of those thrombotic events, 9 were acute pulmonary emboli. One was a DVT and one was an aortic thrombus. Notably, C-reactive protein was higher in those with a thrombotic event than those without. So again, we're back to C-reactive protein, which is a complement protein. C-reactive protein is actually part of the innate immune response, and it's made by the liver and is released. Has a kind of a dual impact on coagulation because it may enhance some of the classic pathway, but also may inhibit parts of the lectin pathway. So when you see a lot of C-reactive protein, you think, well, something's going on either to incite a protective mechanism, or it might even be a not very protective mechanism. But you start worrying a little bit about coagulation. But it's also a complement protein. And it should be pointed out that there's a wide literature on COVID-19, many papers now that are reporting high levels of C-reactive protein in a lot of these patients. So also on this poster, if you look at the middle graph at the left, they were looking at the percentage of patients who tested positive for antibodies who did or did not have a thrombotic event. And in the darker reddish or orangish color, you can see that if there was a thrombotic event, which is represented by the plus signs, there were more people who had anti-beta-2 glycoprotein 1, anticardiolipin, and especially lupus anticoagulant. And then if you looked at the percentage of patients with single or double or triple positivity, not surprisingly, the darker colors representing the double or triple positivity, there were more with thrombosis than without thrombosis. And then there was a plenary session looking at 172 patients hospitalized with COVID-19. This was presented by Dr. Zoll from University of Michigan, and looked at the different types of antiphospholipid antibodies. And here they included a study of antiphosphatidylserine prothrombin antibodies, which I mentioned before. And if you look at the IgG and IgM, phosphatidylserine prothrombin antibodies, which are in the middle here, you'll notice that there are just an awful lot of boxes checked, more than the other antibodies. So these antibodies are associated with neutrophil activation, more severe respiratory disease, release of neutrophil nets, which is an inflammatory sign and suggests type 1 interferons are active. Type 1 interferons are also part of the innate immune response, and they are important in the inflammation that's associated with that, and get associated with complement activation. There were increased thrombi in mouse models and increased neutrophil nets in mice. They noted that final finding, the increased neutrophil nets, which were quite substantially increased, were a little bit similar to what they have previously reported in studies of the catastrophic antiphospholipid syndrome. To remind you, the catastrophic antiphospholipid syndrome was described by Ron Ascherson in 1992, is characterized by rapid onset multi-organ failure with small vessel thrombi, and is differentiated from primarily large vessel occlusions of APS, but it does include large vessel occlusions. So you get large vessel clots and you get small vessel thrombi. 40% of people with the catastrophic antiphospholipid syndrome do not have lupus. So although it's highly associated with lupus and has many lupus-like features, almost half of the patients do not have lupus. There's a very poor prognosis if it's untreated, but we've known for many years that it's improved by multiple agents together. You have to be quite aggressive, and so such interventions as plasma exchange, heparin, IVIG, plus or minus steroids, and in fact, in the past, we used cytotoxic. We have some more modern treatments today that I'll get back to. So look at the kind of organs that are highly represented in patients with CAPS: renal, pulmonary, cardiac, cerebral, and cutaneous. All of these organs are very classic in patients with COVID-19 coagulopathy. In fact, the catastrophic antiphospholipid syndrome is related to a broad spectrum of thrombotic microangiopathic syndromes that include the hemolytic uremic syndrome, what's called atypical hemolytic uremic syndrome, which I actually think is the hematologists robbing us of our autoimmune patients and making it their own, and also what used to be called the TTP of lupus. And there's also, of course, a genetic thrombotic microangiopathy called TP, but they're very similar to each other. And lupus, it's acquired. So there's a spectrum, and I colored everything in caps yellow, and then I asked which of these other syndromes share these features with the catastrophic antiphospholipid syndrome. And you can see that as you go across, there are varying ways in which they do or do not share features with the catastrophic antiphospholipid syndrome, but there is a great deal of overlap. Notably, DIC is the thrombotic syndrome, which is the least like the others. But also, I want to call your attention to complement activation. All of the, except for DIC, all of the syndromes share complement activation as a major feature, and they're now sometimes being called complement-mediated thrombotic microangiopathic syndromes. Now, if you look at the complement system, what you see is that it can be activated in various ways. And these thrombotic microangiopathic syndromes actually have been found to activate complement in all three ways. And notably, in the complement pathway, CRP does play a prominent role in activating the classical pathway and inhibiting the lectin pathway. All of these pathways end up at C5, and when you get to C5, that's when you get the membrane attack complex started, as well as pathological features of the breakdown product C5a. So complement components activate platelets and induce tissue factor on endothelial cells and monocytes and neutrophils. Complement is very much tied up with a coagulation system. And recently, eculizumab, which is an inhibitor of C5, basically stops the entire complement system short, regardless of which pathway it came down, is also associated with decreased interferon signals and decreased evidence of activated complement pathways, obviously. But the point is that it also seems to decrease interferon signals. And of course, interferon has direct effects on the complement and the coagulation system as well. So all of this is tied together. And what we're really looking at is an important overlap between innate responses to viruses. And remember, we never saw COVID-19 before. So we need our innate immune system because it takes us some time to make antibodies. Hopefully we'll do a little better after we get protection. But at this point, we really have to rely heavily on the innate immune system. And you can think of the very severe COVID-19 pathology as an innate immune system gone awry because it's not getting rid of the virus. In fact, the virus has ways of avoiding some of these innate responses, and that just makes them get worse, and that's how you get severe disease, and that may be how you get the coagulopathy that's been described. Anyway, eculizumab has now been described in case series. We don't have too many randomized controlled trials here, but quite a few case series reported of it being effective in the catastrophic antiphospholipid syndrome, all the other thrombotic microangiopathy syndromes, and in fact, recently, some case reports of it being quite effective at reversing severe COVID-19 disease. Of course, look, we've known for a few months now that there's a striking prevalence of thromboembolic events that were unexpected in COVID-19. If you think about how it compares to other viral infections, including other coronavirus infections and including other kinds of illnesses that cause people to go to the ICU. For example, in one study of 1,000 patients with COVID-19, 40% had thrombotic risk factors. And importantly, severe thrombotic events have been seen in younger people who don't seem to have risk factors. Occasionally, that's the presenting sign, some absolutely catastrophic event, which looks a lot like catastrophic antiphospholipid syndrome in relatively young patients. One thing that has been noticed is that patients can develop severe gas exchange deficits, even though they have well-aerated lungs, suggesting multiple microthrombi. In the beginning, this was widely interpreted as DIC, and there were low platelets observed, although not very low platelets. And of course, there was a metabolic acidosis that sort of led people to think that, and they were looking at the elevated LDH and D dimers. However, and this is a presentation that you can see from the ACR from Cynthia Magro, one of her earlier papers back in the spring, I believe, described 5 patients with COVID-19 respiratory failure. And what she found in the lungs is there was minimal inflammation, fibrin deposits, neutrophils in the interalveolar septae, and microvascular deposits of complement components, as well as mannose-binding lectin-associated serine protease, which is an important component having to do with complement activation along in the lectin pathway. 3 of the 5 patients had purpuric skin lesions very similar to what's sometimes seen in the catastrophic antiphospholipid syndrome. And 2 of the 5, she found COVID-19 spike glycoproteins found in association with complement components in the interalveolar septae. She concluded that there was a catastrophic systemic microvascular injury that was mediated by activation of the alternative and lectin-based complement pathways. And you could have been describing the catastrophic antiphospholipid syndrome here. Since then, a number of other pathology reports have come out confirming this. This is not what's going on in every patient with COVID-19, but somewhere along this spectrum, we are describing a rather surprising percentage of people with severe COVID-19. Now, I put COVID-19 thrombotic microangiopathic syndrome on the left here and colored it all yellow, and then looked at how similar the other thrombotic microangiopathic syndromes are to it. And what we got was a 1-to-1 correspondence with catastrophic antiphospholipid syndrome and quite a lot of correspondence with all of the others. So it looks as if this is very similar. It's not the same thing as what we used to call catastrophic antiphospholipid syndrome, but we may need to expand our thinking in that direction. So EULAR gave us recommendations for treatment of the catastrophic antiphospholipid syndrome that are a little updated after many decades of treating these patients. And so the first line of treatment is combination therapy again, and they recommend combining glucocorticoids, heparin, plasma exchange, or IVIG, as we've known for quite some time. And they were able to find enough literature to say they recommend this over any single agents. Obviously, you do want to address precipitating factors, and so that leads us, if you think about it, to think about what is precipitating. In the case of COVID-19, it may be COVID-19. If the catastrophic antiphospholipid syndrome does not respond, and I'm going to add my own recommendation here, it better respond pretty fast because you're in a lot of trouble if it doesn't. So I would say within a week, you should be considering B-cell depletion with rituximab, which has a good anecdotal profile, or complement inhibition, thinking about eculizumab. So EULAR has already gotten there with the catastrophic antiphospholipid syndrome. We published a large literature review earlier in the fall, and looked at all of the publications that had come out up through about August 1st, and more have come out since then. But on the basis of a pretty large literature, most of which is unfortunately anecdotal obviously, because we're very early in COVID-19 disease, we suggested that some kind of treatment similar to what we use for other thrombotic microangiopathic syndromes should be considered for COVID-19 coagulopathy.
Okay, thank you very much, Dr. Joanne. Very informative and very practical lecture. I enjoyed it very much. Thank you. As I expected, there are 3 questions on antiphosphatidylserine.
Yes.
Why it is not included in the criteria? And if it is only positive with recurrent thrombosis, do you anticoagulate or not?
If I saw a patient with antiphosphatidylserine prothrombin antibodies, in my mind, I would be worried that this might be very similar to having a lupus anticoagulant because there's a great deal of overlap between those two. And the question of why isn't it included as a major antibody to measure, I've been asking that for about 20 years, so I don't know the answer.
I remember some authorities in antiphospholipid a few years ago, they said antiphosphatidylserine is useless test. We don't use it in our lab and we don't look at it. But in practice, we used to see patients with recurrent thrombosis, and yet the only positive test is antiphosphatidylserine. Of course, we didn't follow them and we anticoagulated our patients because of the history.
Well, thank you for saying that, because I have had the same experience, and I've had patients with very bad thrombotic diathesis, and all I could find was antiphosphatidylserine. It wasn't the new way that we measure it with prothrombin. It was just those old antiphosphatidylserine antibodies where the plate was coated with phosphatidylserine, and you checked for antibodies. And I have to say, I've always thought that was the antiphospholipid syndrome.
There's one question. Are there any cases report of thromboembolic events in post-COVID recovered patients?
I'm not that familiar with the literature, but I will just say this, that I would expect there to be.
Okay, there's one question about how to differentiate between lupus vasculitis or APS in a patient with right upper limb minimal weakness and seizure, and MRI came with multiple deep white matter lesions. So how can you differentiate?
If you have vasculitis, that doesn't mean you can't also have APS. So I would sort of accept the notion that you could have an even worse risk if you had a lot of inflammation in the blood vessels that we understand as one of our vasculitides, and then you also see antiphospholipid antibodies. So what that would tell me is that I need to treat immediately the inflammation of the vasculitis, but that I might want to consider more long-term coagulation.
There's one question on perioperative management in cases of APS with arterial but not venous thrombosis in terms of safety versus risk of ASA discontinuation.
I think arterial thrombosis is very scary because when you begin to have that, these are patients where they could have a very catastrophic event. And I didn't mean that as the catastrophic antiphospholipid syndrome. I simply mean we're worried about strokes, we're worried about heart attacks. So I would just say that's a patient that I would consider high risk for recurrence, and I would want to treat very aggressively if they have the antiphospholipid syndrome, sorry.
Okay, there is no more question. Thank you very much, Dr. Joanne, and thank you for all audience for their patience. And I hope that this event was fruitful to them. Thank you very much.
Thank you.
Thank you, Prof. Joanne, for your excellent lecture, actually. Thank you both. So coming to the second day, our honor tonight having such key opinion leaders and the renowned ACR faculty with us. It was really very informative, excellent lecture. We gain a lot. I wish that all of the attendees having a nice, they have a good and confirmation from what we saw. Tonight we have Professor Joan Merli, Professor Michelle Betry, as well as we have Professor Chester Oddy and local excellent speaker. At the same time, I would like to thank all the chairperson for their excellent sharing and discussion. Dr. Ramz Swalim, Professor Sami Bahlas, as well as Dr. Fahed Al-Anizi. Tonight also we finalized the second day of pediatric rheumatology, and from tomorrow, inshallah, we'll join together. We have a very excited lecture tomorrow. So being with us tomorrow, inshallah, at the same time at 7 p.m. Thank you again for the organizing committee and the scientific. And I wish to see you, Prof. John, with us, inshallah, in our annual meeting in Saudi Arabia, live, and this COVID-19 resolved, bidnillah. Thank you again for all audience for being with us till now. We have a good number of participation from Saudi Arabia as well as from a different country. So be with us tomorrow and after tomorrow, inshallah. Thank you. Bye.